Hey everybody. This week I have ossicular chain discontinuity. Um, what is it? It's pretty simple. It's just the displacement or the fracture of the ossicular chain or any of the ossicles within the chain. The site of lesion, obviously, the ossicular chain, which is in the middle ear. I included this picture. This is actually a picture I took in class last semester in Intro to Audiology. I just wanted to remind you guys how small the ossicles are. I mean, you can see those are my fingers in comparison, like they're extremely tiny. So ossicular chain discontinuity is basically when any of these bones gets fractured or gets separated within the chain. And then some signs and symptoms. Patients can experience hearing loss. This will be a conductive hearing loss or a mixed hearing loss. They might experience tinnitus. Blood can be present in the external auditory meatus from the fracture. Fluid might also be in the middle ear if the fractured bone perforates. Yeah, then there it says the perforated tympanic membrane. So the ossicles, if they break, they can actually puncture through the TM. I guess I didn't really put this information in the best order, but okay. So basically, an ossicular chain discontinuity it's caused by well, most often is caused from some sort of trauma to the head. Individuals who have this, 50% of 50% of these patients, whoa, let me back up. 50% of patients with temporal bone fractures also have ossicular chain discontinuity. And then after the head injury, the trauma, 75% of patients report that they are experiencing hearing loss in the first week. And there's not really like any specific population that is affected by ossicular chain discontinuity. But the most common group, I guess, are young males ages 16 to 30, but it can occur to any gender at any age. Okay, this will kind of help explain better. So ossicular chain discontinuity occurs after trauma. It can also occur from a cholesteatoma or congenital disease, but the majority of cases are caused by trauma. And it's usually due to the erosion of the ossicles. It can also be caused by middle ear infections or malformations of the ossicles. And like I mentioned earlier, fracture of the temporal bone, cholesteatoma. But most often it's from trauma, and the most common mechanisms specifically of trauma include road traffic collisions, falls, and interpersonal violence. So yeah. And then to diagnose ossicular chain discontinuity, most patients will get a CT scan following the head injury. And then the CT scan, it will show if there is a fracture in the temporal bone. If there is a fracture in the temporal bone, then that's one when they start to kind of wonder if the ear has been affected. But obviously, like, doctors are looking to rule out any serious head injury before they're looking at injury to the ears. But a patient can get an audiogram done. The audiogram will reveal if there is hearing loss or not. If the audiogram does show a conductive hearing loss, it is either ossicular chain well, most likely it's either ossicular chain discontinuity or the hemotympanum. And so to roll out the hemotympanum, an audiogram should be performed again after 6 weeks after the initial audiogram was performed. And that's usually the time frame that a hemotympanum should heal. So after 6 weeks, that should heal. And if the conductive hearing loss is still present, then there's a good chance that it is from ossicular chain discontinuity. This isn't super common, but tympanometry can show an increase in compliance, which would just show that like the ossicles are moving around way more than like they typically would. So if they're disconnected. And then, okay, so a normal CT scan, a normal head CT scan is not going to show if ossicles are damaged, but we can get a more specific CT scan, a CT temporal bone scan, and that sometimes will show if the ossicles have been damaged. Not always, but it can appear on the CT temporal bone scan. But really, to know for a fact, usually audiologists have to go in and have or perform surgical exploration of the middle ear to see really what's going on. And then treatment and management, it's basically surgery or hearing aids to fix, or I guess, yeah, to help the hearing loss. The most common surgery is an ossiculoplasty. And this surgery is used to rebuild or replace the displaced or broken ossicles. So they can be replaced with pieces of bone or cartilage. They can also be replaced with prosthetics. And then this is a cool fact that I found. If the stapes is still intact, the rate of a patient recovering their hearing loss, like having a good hearing loss recovery, is 75%. If the stapes is not intact, though, that recovery percentage goes down to 50%. And then this one was kind of interesting. So once this is, I guess, like, it's suggestive that there might be ossicular chain discontinuity, a lot of patients don't actually have surgery to like to mend the like to repair, I guess, ossicular chain until 5 years after the injury occurs. And I was wondering why, and so I was digging a little into this. And so a lot of the reasons are if the patient still has one good hearing ear, they're not like super concerned about fixing the other one like right away. And also, like I said back in the very, very first slide, these bones are so tiny that like this surgery is really, really hard to execute perfectly. And so a lot of risks come with the surgery. It's not like an easy fix. And so sometimes like patients view the surgery as more of a risk than anything else. And so, yeah, they're not like super quick to jump on the, oh yeah, I'm gonna go, get my ear cut out, because a lot can go wrong and the surgery can actually result in permanent hearing loss. But with ossicular chain discontinuity, it's most often the hearing, if there is a hearing loss present, it most often is just conductive. And so most patients opt for the hearing aids. You can just get hearing aids to receive the cochlear stimulus instead of going through the outer and middle ear. And then here is a little YouTube video. This is a video of a doctor. He's actually reconstructing the ossicular chain, and he's adding prosthetics into the middle ear. So I just thought it was cool. I'm not going to play the whole thing because it is kind of long, but I did want to show you.
Or a little bit inferiorly, that keeps you out of the region of the chordae tympani. After you get a good peek into the middle ear space, typically use a sickle or a rosin to dissect sharply. You want to preserve your chordae tympani nerve if it's present, and to gain good access. In many cases, you'll need to curette the scutum to get a good visualization of your region of your stapes superstructure. In this case, most of this work was done from his previous operation. Through this view, I was able to see the superstructure very well, and I was able to see the displaced prosthesis as previously demonstrated on the CT scan. I removed his previous prosthesis and elected to place a prosthesis that has a coupling mechanism that will hold to the superstructure better. There are several companies that make these newer prostheses, including the Bite and the Clip. These prostheses in particular have a very light metal that will couple nicely to the superstructure. When you're using these prostheses that couple to the superstructure, they're less likely to become displaced even with trauma or hitting your head. So they're beneficial from that standpoint. You do have to make sure that your superstructure is oriented the right way for them to work. So uncommonly, you can have a superstructure that's tilted very severely inferiorly. For example, it's difficult to attach one of these coupling prostheses in that situation. You can have a severely malformed or eroded superstructure, and that also makes it less conducive to using one of these clip prostheses. In this case, I sized the gap between the tympanic membrane, the cartilage, and the superstructure, and based on that size, I placed a prosthesis. The prosthesis, when you're introducing these prostheses, you have to be very careful not to bump the sides of the speculum or something else with the prosthesis because you can bend the legs on it and make it more difficult to place. Once you get your prosthesis in place, you'll apply a very gentle downward pressure on the stapes superstructure until you see it coupling. If you push too hard, you can sublux your stapes. And so again, you want to do this very carefully under direct visualization as you're coupling it. After it's coupled in place, you'll lay your tympanomeatal flap flat against it to make sure you have good approximation. To get good coupling, I like to have just a little bit of tenting from the prosthesis into the.
Okay, yeah, so that's just a little bit of what the reconstruction surgery looks like with the prosthetic. And like, just to remind you guys, I mean, those things are tiny. That's like, I don't know, I am mind blown that these surgeries are even possible with how extremely tiny the prosthetics are and the ossicles are. And I don't know, I just think it's all really cool. But yeah, that's all I got this week. And then here are my sources. All right, everybody, have a great week.